So we are here this evening talking about BEPOP. We're going to be talking about the learnings from wave two of BEPOP, and I will hand over to our speakers very swiftly. But just a couple things before I do. Please, as we're going through, please, if you aren't speaking, please have your mics off just to make sure that there is no interference and background noise. We are very excited about this webinar and we hope that you enjoy it. So please do engage with the speakers, with the discussion sections. We have function and also the chat box as well. So please do add your comments and your questions and things in there throughout, but also when we come to the discussion and Q&A sections. So for those who don't know what BEPOP might be, BEPOP is a service development project. It's a UK-wide benchmarking and feedback system for exercise prescription for older people who have frailty and sarcopenia. We are obviously quite biased and very excited about it, so I won't go too much into the results. I'll let our speakers do that. But I will say, as I said, please engage, please interact with the speakers as we go through, and we hope that you enjoy the next hour and a half of our wonderful webinar and results. So I'll hand swiftly on to our first two speakers. So first off, we have Alex Kropp, who is a consultant geriatrician based in Newcastle, who has led the data collection and analysis for Wave 2 of BEPOP. And we have Samantha Hartley, who is a specialist registrar in geriatric medicine based in the northeast of England, who has co-led the data collection and analysis for Wave 2 of BEPOP. So over to you, Alex and Sam. Thank you so much.
Thank you very much. Bear with me while I do that awkward screen sharing part.
No worries at all.
Lovely. So hopefully you can see my screen. Sammy and I are co-presenting, but from completely different locations. So bear with us. I'll be moving the slides for both of us talking. So thank you for that introduction. As discussed, BEPOP is a benchmarking exercise program for older people. There we go. So I'm just going to get rid of this admitting bit. So why BEPOP? Well, we know that benchmarking systems work. Things like the National Hip Fracture Database and NELA provide kind of a nationwide data source where people can see the data and use it to transform care, and it can be a really, really powerful tool. And we wanted to try and create something similar for sarcopenia and frailty. So we wanted to promote best practice in exercise delivery for older people with sarcopenia and frailty. And the idea was that by comparing against others over time, we can evolve practice, optimize outcome, and spread best practice. So as I said, that was the rationale behind BEPOP. So I'm just going to minimize that. So a cycle, benchmarking the current practice, evaluating that against the current evidence base, feeding back to the participants with recommendation for change. And I would say we've widened that with things like the webinars and looking at producing kind of reports that are available to anyone who's interested, and then benchmarking again, hopefully with more and more people. So the methodology. We wanted to look at UK services, and we've kept it currently to those who are NHS physiotherapy services. We only wanted to include those people that were frail or sarcopenic. And we didn't want anyone who was condition specific, like stroke or cardiac rehab or pulmonary rehab. Each service that took part, we asked to provide data on 20 consecutive patients, and that was submitted anonymously through the online collection tool of REDCap. And then we looked at that data and we produced an overall report with some broad recommendations, and there was also tailored individualized feedback to each site. And the thing we really want to get out of BEPOP is this kind of idea of a community of practice. So we want people to share ideas, share challenges, share what they've learned, how they've changed things in response to it, and things they found tricky. And that's what this webinar is aiming to build, is to have sort of sites that have done really well, or things have made big changes. And really, I'm just here to tell you about it, and they're going to tell you how you can make your services great.
So can everyone hear me okay? I'm just going to take you back and do a recap of Wave 1, which was done a couple of years ago, and the key findings from that. So Wave 1 was a relatively small pilot study. We recruited 10 sites, again asked for 20 patients per site. Didn't quite achieve that, only got 188 patients in total. And this was an information gathering to try get a baseline of where we felt services were at to try work out what we needed to improve upon. The data we gathered from that showed that things weren't particularly ideal. Only 60% of patients were having any form of strength-based assessment of their physical performance. Measuring strength as a measure of sarcopenia is really quite important, so you kind of get a baseline of where people are at. And only 70% of patients received any form of reassessment during their program, and often it was not the same assessment method used at the baseline, and therefore making direct comparisons and showing direct improvement can be quite difficult from that. Almost all patients received some form of resistance exercise training, which again is the kind of the key evidence base behind improving outcomes in sarcopenia. For a lot of patients, so just under half of patients, the only resistance exercise they received was some form of body weight exercises, and that is kind of something to reflect upon. How would you progress those body weight exercises to continue making improvements? Because the next point that we really noticed was that only just over a quarter of patients had any progression of intensity of the exercise. So that be things like increasing the kilograms of weights used, increasing the strength of any resistance bands used. A lot of patients had it progress by volume, so increasing the number of exercises you did, but just not the intensity of those exercises. And again, that's really important for helping to build muscle strength. And only 41%, so less than half of patients, had any sort of ongoing signposting or referral to follow-up programs to help them maintain or continue the improvements that have been made during the exercise program. We also got the opportunity to get some qualitative feedback from Wave 1. We had 8 clinicians from 5 of the services involved have a Teams interview with us to tell us about the project, how they felt, some reflections from it. And overall, that qualitative feedback was very, very positive. There was a good demonstration of reflection on individual practices and a drive to improve services, as well as a hunger for more knowledge and training, hunger for how we can improve things. And from that, we've sort of tried to progress those shared experiences, highlight the communities of practice, provide webinars, and support with how you can change what your local services do. From Wave 1, from the data from Wave 1, we developed 5 key recommendations. These are assessment, diagnosis, exercise prescription, progression and reassessment, and take forwards. We wanted to keep things short and simple because that is how we can really focus in on making the key changes. So for those of you who've been involved in some of the waves, you may recognize that these on this slide, things are paraphrased slightly to make all the information fit on one slide, but we will cover the exact wording of the recommendations later in the presentation. As a brief summary, all patients should be assessed using an objective strength-based assessment method before starting an exercise program. And the keywords to highlight here are the objective strength-based assessment. So we are well aware that lots of patients will receive assessments, and they might be functional assessments such as the timed up and go and gait speed, but having something objective, measurable measure of muscle strength is key to helping improve outcomes and key to measuring and diagnosing sarcopenia. Diagnosis, I think, is fairly straightforward. By recognizing sarcopenia, highlighting sarcopenia, documenting it, and sharing it with the other services involved in that patient's care, we can really highlight what needs to be done. As sort of physiotherapists, as physiotherapy practitioners, it's not your role to necessarily provide those other services that are going to be important in sarcopenia, like maintaining adequate nutrition, but by diagnosing and highlighting it, we can pass that forward onto the appropriate services. Exercise prescription should include resistance exercise training for all people with probable or confirmed sarcopenia and or frailty. It's the resistance exercise that holds the best evidence base for improving outcomes in sarcopenia. And if you kind of put it into a bit of context, go sideways, you want to improve the patient's muscle strength, and you wouldn't expect an athlete to improve their strength just by doing cardio-based exercises. You'd expect them to include some form of weightlifting or other type of similar activity to do that. In terms of recommendation 4, progression and reassessment, the resistance exercises should be progressed by increasing the intensity of the exercises as well as increasing the volume. It's very easy to just say, yep, do more of the same exercise, like each day do a little bit more, do a little bit more. But it's important to make sure that we're also increasing the kilograms of weight used or the strength of the resistance bands as well, to again just really focus in on improving that muscle strength. And at the end of an exercise program, all patients should be reassessed using the same objective strength-based assessment method that was used at baseline, so you can really see those key improvements there. In regards to take forwards, all patients should be offered education about the benefits of exercise and signposting or referral to for ongoing exercise services. We really need to support the positive changes that have been made for this patient and make sure they're not just going to fall off the perch and not do this and revert back to being just as sarcopenic as they were before the exercise program started, because that doesn't do anyone any good.
Lovely. Thanks, Amy. So coming on to wave 2, you can see from the map of wave 2, we've got lots more dots. So the dark blue were new sites and the yellow are returners. We had really good initial interest, but I'm sure for any of you who've done a project will note the amount of people that kind of got through to actually getting logins and things was 33. We did exclude 9 from the initial sites because of eligibility criteria. We got a total of 28 sites contributing data, which is great. So 10 from the first, 28, big increase. And as highlighted, 7 of those sites were returners from the original 10. The drop off of the 5 was because 2 felt they were unable to complete the data by the deadline, and 3 just stopped responding to us when we started asking them to submit data. Baseline characteristics across the 2 were fairly similar, actually. So you can see that the average age is the same and slightly higher percentage of women rather than men attending. I think, as you would expect with what is essentially a community-based physiotherapy program, the majority of patients were living in their own home. The eagle-eyed amongst you will note that the reason for referral adds up to more than 100%, and that's because when we did this, it was a free text section. So often people were referred for lots of reasons, and we sort of grouped them into these common headings. We did fall slightly short of our target number, which was 560. So we had a total of 542 because there were a few sites that didn't quite get to 20 because of their time constraints, but we wanted to keep in their data and have that as a kind of valuable amount.
So moving on to looking at how well the different services managed to attain the sort of achievement towards the recommendations. So this is an anonymized waterfall plot of each of the 28 sites, how well they managed to perform compared to the recommendation, and the red line shows the average across the board. So recommendation 1, that all older people referred for exercise programs should be assessed using an objective strength-based assessment method, such as 5 times sit to stand before starting an exercise program. 7 sites managed to achieve this for 100% of their patients, but unfortunately 6 sites did not achieve this for any of their patients, and the average across the board was 51%. The objective strength-based assessment methods we looked at specifically were hand grip strength, 1 rep max, 5 times sit to stand, and 30-second sit to stand. We did also offer sites opportunity for a free text other strength-based assessment box, but on reviewing the the entries that were included there, unfortunately, we didn't really feel we could include a lot of them, because some of them we didn't feel were strength-based and were balance exercises or balance assessments or functional assessments, and others, such as the Oxford MRC grading for muscle strength, we felt had an element of subjectivity to them. They're not fully objective, so that's why we have stuck to those. So if someone's looking at their data going, thought we did a little bit better than that, that is probably the reason as to why. So we do, sorry, it's all right. So we do recognise that function is important, and functional assessments are going to be an element of this, and this is probably what the patients will want to improve upon, their function rather than specific strength. But we are trying to keep this, again, just to highlight the evidence basis for improving the strength. So just to keep coming back to that point and really hammering it in. Thanks, Alex. Recommendation 2 was regarding diagnosis of sarcopenia. So probable sarcopenia can be diagnosed as per the European Working Group for Sarcopenia in the Older Persons guidelines and diagnostic cutoffs using objective strength-based assessment methods by measuring grip strength and 5x sit-to-stand test. This should be clearly documented and shared with the patient's GP. So in regards to diagnosis, we looked at data both pre-referral, whether the patient had a diagnosis or an exclusion of sarcopenia documented in their notes prior to referral, and whether they'd received one by the end. So this is just the overall data for how many patients had a diagnosis by the end of the programme. And again, it shows a very wide variability in performance across sites. 5 sites managed to achieve this for 100% of their patients. 5 sites did not achieve this for any of their patients, and the average overall was 58%. Interestingly, a lot of patients, 41% of patients, had a diagnosis of sarcopenia prior to their referral, which left 320 patients without a diagnosis at the start of the exercise programme. Of those, only 94 received a diagnosis during the exercise programme, which is only 30% of those that did not have a diagnosis receiving a diagnosis at any point during the programme. And again, just to reiterate, that includes a diagnosis of or an exclusion of sarcopenia. Recommendation 3 is in regards to the exercises we prescribe for our patients, and already this waterfall plot looks a lot better in my eyes. A lot of sites, 16 services, managed to prescribe some form of resistance exercise training to all of their patients, and there was nobody that no services, that got none of their patients having any form of resistance exercise training, and the average across the board was 92%. So these numbers feel a lot better on the value of it. The types of resistance exercise training that was offered was bodyweight exercises, free weights, resistance band, resistance machines, ankle and wrist weights. And again, we offered the opportunity for people to add in free text boxes into that. And a lot of what was coming up in the free text boxes we felt was either not a resistance exercise or categorized into one of these categories. It's also important to note that a large proportion of patients had only bodyweight exercises prescribed for them to. Again, we haven't looked at that specifically in more detail as yet, but it's something that we are reflecting on going forward into further waves.
Coming into the recommendation 4A, which was that resistance exercise should be prescribed by increasing intensity and not just by increasing volume. So as Sammy touched on earlier, using more weight, using stronger therabands, something like that. You can see this wasn't done particularly well. So 1 site managed it in 100% of their patients, but 5 sites didn't achieve this in any of their patients. And again, as Sammy touched on, if you were one of the sites that took part in this and you thought you were doing that, I will say that if we looked at those that were increasing by volume and or intensity, the average went up to 86%. So I think lots of people are getting ongoing sessions with people offering more volume, but the recommendation and the evidence base would be that we need to increase the intensity, not just the volume. Recommendation 4B is that we should be reassessing people using the same objective strength-based assessment method that was used at baseline, so a paired outcome assessment to assess progress and guide ongoing prescription. Sammy has touched on what we, for the purposes of this benchmarking program, said were objective strength-based assessments. And you'll note that the numbers are less good here at the end than they were at the beginning. So whereas in that initial recommendation, 51% of patients were having an objective strength-based assessment, only 38% of patients were getting that same objective strength-based assessment at the end. Some patients, when we looked at the data in a bit of detail, were getting two completely different assessments. And I think we can agree that if you're taking the time to do the assessment, it's probably worth repeating the same one, because then you can look at progress. I will also note that when we looked at the data, there are some sites that are doing duplicate assessments, and I don't deliver outpatient physiotherapy, but I wonder whether just doing one assessment and repeating the same assessment is a kind of a better use of time, though I appreciate people might be doing it for sarcopenia diagnosis at the beginning. When looking at the assessments used in wave 2, so the blue bars are what was done at baseline and the orange bars are what were done at post-intervention. As shown by the previous waterfall plot, you can see that we're doing, the sites are doing much better at assessing pre than they are assessing post. As Sammy touched on, the ones that were kind of other strength-based were often manual assessments or an Oxford grading. And then the other generic kind of bar, the one just in from the left, was a wide variety of things, including Berg balance, Tonetti tests, and 180-degree turn. Obviously, it depends what your patient's been referred to your service for, but as we've touched on throughout this presentation, we'd be looking to do kind of an objective strength-based assessment, which is one of the any one of the first 4 bars. One of the things that was probably lacking in this wave of the assessments was that we didn't have any capacity to collect qualitative data. So what we haven't been able to establish is kind of why people chose one methodology over another, or what the barriers were to repeating an assessment at the end. And that's one of the things we'd like to look at going forward. Lastly, we've got recommendation 5. As Sammy said, really important that things don't stop with that intervention. Obviously, you'll have a cohort of motivated patients who will continue to do things by themselves, but going forward, it would be helpful if people had somewhere to go after their intervention. And that was only done for 44% of patients. Good news, every site was doing some form of onward referral. And I will say that a bit of a limitation in our data was that if the patient refused, we couldn't really kind of capture that in this version of things. So I suspect this is maybe a bit of an underreport, but still well below half and well below what we'd be aiming for.
So when we think of how wave 2 has compared to wave 1, this is a table showing the percentages and the numbers on for each recommendation. I'm not going to go through and read all the numbers exactly to you. I'll give you a moment to read that yourselves, but just to kind of show you the color scheme that we have chosen here. If a thing is highlighted in red, it shows that the attainment for wave 2 was worse than the attainment for wave 1. So there's been a bit of regression there rather than improvement. If something is highlighted in yellow, if there was a less than 5% change either way. And if something is highlighted in green, it means it's an area that has shown improvement of more than 5%. And as you can see, really, really pleased to note that the majority of the table is green. Some areas that still need a bit of work, but everywhere does seem to be making improvements across the board. The 2 columns on the left are showing the overall sites, so every site that was involved in wave 1 and every site that was involved in wave 2 and the average overall. The 2 columns on the right are showing only the sites that took part in both waves. So the 7 sites that took part in wave 1, we gathered their data separately, analysed it separately, and did the same for wave 2. So, and if you can see by looking at the numbers that there does seem to be bigger improvements in sites that took part in more than one wave, which shows is very positive and shows that being involved in BEPOP does help you make improvements. It's not just a coincidence because of another site's just happened to have done better. It shows that these sites are making improvements. So the key take-home points we've taken from Wave 2 is BEPOP works. We are improving resistance exercise delivery between the waves, and we've had a talk and have had a reflection on that, and we think there's a combination of effects that's delivering this. So the impact of the publicity and training that we're developing in response to the recommendations, in response to each wave, and the sharing of knowledge across the wider physiotherapy community will be certainly helping things. But also we're hoping that the specific effect, the benchmarking and feedback in that is being delivered to the participating sites. So each site getting their own individual data to show the areas that they are strong with, the areas that they perhaps need to work on. It's information they can take back to support building business cases for more funding, for more supplies, for improvement of their services. So we're hoping that that is helpful and is having an impact on individual sites. There is still room for improvement. As you can see from the tables, not everywhere is achieving 100% for everything, which would be absolutely ideal, although we recognise may not always be realistic. So as close as we can to 100%. We feel and we are seeing increasingly high levels of engagement and interest from the community and a big wider push. So for example, for Wave 3, I believe we are up to 46 participating sites, which is a bigger number than the 28. And we've had more interest as well that we've had to say, unfortunately, you've not met the deadline, but we'll keep in touch with you for Wave 4. So that is doing really well. We are really getting really positive engagement. We're finding that the training and knowledge exchange is being really valued. The sharing of ideas, the sharing of this information, the feedback that we're getting in when we present this or when we have conversations with people about it is really positive. And we find we're now in a position that we have established what we're doing, we've established our processes, and we're comfortable with moving this to an annual quality improvement project so we can continue to provide annual data on improvements and annual feedback and support to help services develop and improve. We have kept to the same 5 recommendations, but we again, to keep things clear, to keep that focus in on what we feel is the important messages from BEPOP, but we've added some enabling recommendations to support sites in improving and support sites in what they can do to attain those recommendations. The first one is that hand grip dynamometers should be made available to all practitioners to facilitate muscle strength measurement. I think this is key. It is one of the ways that we can help diagnose sarcopenia. It is simple, it's fairly easy to be trained to use this, and therefore it should be something that is available. Staff undertaking the strength assessment should be trained to do so with training documented in departmental training logs. Being trained, being knowledgeable in this is key and it is important. We're aware that services are stretched, people are thin on the ground, staffing is difficult, and sometimes we recruit other people to support us that may not have the same training as we do, but it's important that if they're doing these assessments, they should be trained to do so. And finally, that all services should define and document an onward referral pathway for people with sarcopenia or frailty within local NHS, third sector exercise services and private services, including documenting if a patient has declined an onward referral. This is key for that, maintaining those improvements, and we're aware that every locality is going to be very, very different in what they have and what they can offer, and services are changing all the time. So we appreciate the difficulties with this, and we appreciate that things are going to be different for everyone, but it's something that should be very clear to practitioners so they know who to refer to, who they can refer to, and how to do that.
I'm going to speed through this bit because I'm aware we are over time and you're giving up your evening for this. So If you want to read about it in more detail or take things back to your department, the report is available on the website there. And the webinars are to share this community of practice. That's where we feel kind of the real value and learning comes from for this. We're also looking to write this up as a paper for Age and Aging. And we're doing some sub-analysis of the data from Wave 2. You can see I haven't updated this since Sammy spoke, but we have 46 sites now taking part in Wave 3, and we are planning ahead to Wave 4. We're also looking at developing some training resources for sarcopenia and some information sheets for patients to help support sites and provide kind of shared knowledge, and also get everyone singing from the same hymn sheet, I guess, would be the thing. We'd really love to hear from you, and we'd love to know what you think would be helpful, how we can support you as sites, and also what you think would be useful going forward in terms of development. So if you have any questions, you can either go to the website, email us, and obviously we'll now come up to the chat and the Q&A section this evening. I am going to stop sharing my screen so I can see people's faces, but thank you very much for listening this evening.
Thank you so much, Alex and Sam, for giving us that overview of the results from Wave 2 and also the really interesting comparisons as well to Wave 1. We will very quickly move into the discussion section, so I hope that has generated some thoughts for everyone. I see the chat is starting to be active and various things popping up. So we're going to bring in 3 members of the BEPOP team. So who will kind of be having a discussion for the next 10-ish so minutes. So to introduce them, so we have Miles Whittam, who is a professor and academic geriatrician based in Newcastle and is lead for the BEPOP program. We also have Chris Hurst, who is a sports and exercise scientist based in Newcastle, who researches sarcopenia and who sits on the BEPOP steering group. And we have Suzanne Arnold, who is an assistant professor and academic physiotherapist based at Warwick Clinical Trials Unit. She's also an ex-chair of Agile, and she also sits on the BEPOP steering group. So if I can bring the 3 of them in, and we can just have a bit of a discussion and maybe go into some of the points that people are raising in the chat and in the Q&A section as well.
Thank you very much, Rianne. Can you hear me all right? Yes, great. One of the real strengths of BEPOP is the multi-professional and multidisciplinary nature of the program, and I think you've heard far more than you probably should have done from doctors already today. So I'm going to shut up and ask questions, and I'm really keen to bring Chris and Suzanne in. What I wanted to do to start with is to just invite Chris and Suzanne just to reflect on the overall findings of Wave 2 and some of the really good things that have come out and areas of focus. Suzanne, can I perhaps start with you just to give your sort of brief reflections on Wave 2?
Yeah, thanks, Miles. Hi, everyone. I think it's extremely positive that the engagement that we've got in Wave 2 and now going into Wave 3, it's fantastic to see that people are taking up the opportunity to take part in benchmarking their own service to see where they fit within, you know, comparing with other people and with the recommendations. So I think that's really, really great. My worry still is about progression of exercise, and there'll be lots of reasons that people can tell us about why they're not able to do that, usually around equipment and things like that. So that's the one thing that I'm still really interested to find out from people as to why that's not happening perhaps as much as it could be. And I was fortunate enough to lead on the qualitative part of Wave 1 when I did interviews with people who took part in the program for Wave 1, and yeah, there were challenges, and the need for training came across very strongly, and that's something that I'm also hopefully going to be able to help with going forward. So that will be another positive that comes hopefully out of BEPOP as well, that we will be able to provide some really specific training.
Great. No, thank you for that, Suzanne. Chris, can I bring you in for your sort of initial thoughts and reflections on the Wave 2 results?
Yeah, thanks, Miles. Hello, everybody. Well, firstly, kind of Suzanne alluded to it, but I think the number of sites and the amount of patients and the amount of data there was, firstly, is really good progress, and will continue to progress over time. And I suppose related to that is how much improvement there has been across those sites that have taken part in both waves, considering we have only done 2 waves. It has only been a short period of time, but those sites have reported improvements in not much time really. And actually, even the sites that have just taken part in wave 2, the numbers are generally positive, and things have improved even further. Kind of telling us that hopefully BEPOP is having sort of an influence, and there's maybe a bit of a bigger sphere around it as well, in the efforts that we're making to try and share knowledge and disseminate things as well, is hopefully having some influence. Yeah.
Just picking up on that point, Chris, I think one of the things that we've sort of reflected a little bit as the BEPOP team is there seems to be a sort of a general effect of BEPOP, and that seems to be working through events like this and presentations at Agile conference and CSP conferences, that seems to have raised awareness about good practice in sarcopenia. So we're seeing, you know, improvements in wave 2, but there does seem to be a more specific and bigger improvement in teams that have taken part in wave 1 and wave 2, and maybe just to sort of reflect on that a little bit.
Me or Suzanne first? Sorry, me.
Either of you, I don't mind. I'm not fussy.
Sorry, Suzanne, go on. You go first.
I think physios are kind of crying out for this. This isn't the only area I know where physios want to be benchmarking their services to find out how they are doing. So the fact that people have come back to go through wave 2 after going through wave 1, I think is testament to that. They want to see, they want to improve, they want to do the best for their patients. So yeah, I think that was my reflection, Miles.
Yeah, no. I think that's entirely fair. One thing I think that it came up in wave 1 a bit, and certainly I suspect we'll hear more about this, is what else can BEPOP do to help teams, particularly to help teams advocate for change within their local services. One of the things that we always wanted BEPOP to be able to do was to empower local teams to say, here's how we're doing, here's what we want to do to change, and here's why you as an organization, you know, your local trust or practice needs to support us doing this. What else do you think we could do that would be helpful in supporting teams up and down the country to make those changes? Suzanne or Chris first. I do not mind.
Well, I'm not sure I can answer on behalf of teams and services, because I sit in the university office and tell people what they should do. And I think between us, we need to work out how we can do something close to what we should do and what we know works and what is optimal, for want of having some reluctance to use that terminology. But I think kind of in terms of the data that we're collecting and the ongoing waves will help us to make a case, particularly that we've spoke about the intensity issue already a few times, and there are ways and means to try and get around that, but some of that might involve we need some equipment for some patients at some point, and we need to build a case and build some evidence to sort look, it can matter, so it's important. We need to find some money to do this sort of thing. Yeah,
I think that's a good point. I think there's been a little bit of chat in the Q&A or in the chat about dynamometers, and I think it goes back to why we made that specific recommendation. It's not that we want to use that as another stick to beat anybody with. It's the thinking was very much, if we advocate that you should be using dynamometers, that gives teams something that they can take the report and the BEPOP feedback back to their trusts and say, look, national guidance says you should be buying us dynamometers. We hope that making those recommendations will help that process. Clearly, if it doesn't, we'll need to have a bit of a rethink. But it speaks to what you've just said, perhaps. Suzanne, other things that you'd like to reflect on from that?
Yeah, obviously training is a big thing, and that was something, as I say, that came across through in the interviews. And as BEPOP, we have I tried to find some funding to put together training packages for everybody off the back of the recommendations for BEPOP. Unfortunately, didn't get the funding that we needed, but that's something we're still persevering with, that we want to put all of this work together into training packages for everybody, not just for physios, for the whole MDT, about sarcopenia and frailty and what it is and what we can really do to help patients. So that's hopefully something that BEPOP will be able to help people with. I know that's something people want.
Yeah, great. I'm just going to draw this to a close because I'm conscious of time. But there's one really good question that Doreen has posed in the Q&A, which is where's the place of the patient in all of this? And this reprises some conversations that we had after the Wave 1 BEPOP results, and we received a similar and absolutely appropriate challenge. We've now had more time to think about this, so I'm able to now throw this question back at you, Doreen, and say this is exactly where you can solve this. You know, you are the experts in working out how to take evidence-based guidance into practice in a way that it is not just us doing things, but it's actually meeting individuals' needs and it's personalizing care. If you tell us what you need from us in terms of training and education, we can help provide that. But you are absolutely the experts at being able to do that. What we can do is provide you with the data that helps and gives us steer. But what I don't want anybody to think is that there's only one way of doing this, and if you don't do it, that single way, then you get marked down somehow. This is about using data to improve practice, not to just act as a sort of a stick or anything. But I think it's a really important challenge, and that we do need to absolutely make sure that we're centered on what patients need and what patients want, as we're trying to deliver the best evidence-based care. Thank you very much, Chris and Suzanne. I'm going to hand back to Rian now, because I think the most important part of the meeting is the bit that's coming up now, and this is the bit where we're all going to learn loads.
Yeah, definitely. Thank you, Miles. Yes, let's hear from the people who are on the ground. So our first speaker of the next section, we have Gemma Waddle, who is a senior physiotherapist working with the Integrated Independence Team at Homerton Healthcare NHS Foundation Trust. And Gemma is going to be talking to us about how they improved their assessment and diagnosis of sarcopenia. Thank you, Gemma.
Hello, can people hear me?
Yes, we can hear you.
Okay, do I see my slides?
We can't see them yet.
Oh no, I thought Miles was going to share them.
Oh, okay.
Not ready. I'll
is
share for you, Gemma. That's fine.
Beth can share them for you.
I have to wing it.
I've got them ready. Don't worry.
Thank you.
There we go.
Okay, great. So can I forward through these at my own pace, or do I have to ask?
I think you might have to ask me to move them on.
Okay, well, next slide, please. Okay, thank you for inviting us to talk about this. So yeah, we've been doing BEPOP for this is the second wave. So we did wave 1, wave 2. We really found it very beneficial, actually, because it was like someone was marking our homework, and that was actually just so helpful because it really drove us to improve. So a little bit about our service. So we're the Integrated Independence Team at Homerton Healthcare. So we provide community rehab in people's homes in the inner city London borough of Hackney. So Integrated Independence Team is a very big team. So this was carried out in the home rehab part. The demographic of patients that we see is quite elderly and more elderly and more frail than I think a lot of the services who have participated before. So our average CFS is actually 6.5. So not everyone was actually appropriate to do the strength base, but that was part of our QI project, was to help identify and automatically include people who were appropriate. So we provide goal-based intensive rehab for up to 3 rehab sessions per week, maximum of 6 weeks, with the hope that we would refer on for anyone who's appropriate for ongoing rehab to the increasingly limited number of services available to us. Can I have the next slide? So in wave 1, we were pretty much at rock bottom. So there was only one way up, which was good. So our results to work, the things that we had to work on, only 15% of patients had an objective strength-based outcome measure, like a proper one. So a lot of people were just doing muscle grading, which, as has been mentioned, is very subjective. 80% of patients had resistance, but it was body weight only, and as we know, that's not going to really cut it in terms of evidence-based practice. And only 10% were increased with intensity. Otherwise, people tended to be progressed with volume. So we got the help of our QI team, and it actually timed really, really well with BEPOP2, because by the time we got round to involving QI, BEPOP2 had popped up in our inboxes, so that was really helpful. So we decided on a kind of uniform approach, where if we just told people what they should be doing and give people kind of a bit of less choice, really, then we can make some bigger differences. So we said everyone should be using resistance bands, because our therapists travel from house to house, either walking or public transport. People don't want to be carrying around weights for obvious reasons. And we said routinely, everyone, if they can do a 5-time sit to stand, then they should, because it's good for identifying sarcopenia, but also good for identifying falls risk as well. And then we really wanted to improve the number of patients that were progressed. Can I have the next slide, please? So the changes we did, so we did a relaunch of BEPOP2, so let the whole physio team and the assistants know that we were doing it. Got the QI team involved, as I said, did some team teaching about sarcopenia. We did a broadcast to the team of the British Geriatric Society webinar about sarcopenia and evidence-based practice, which was perfectly timed. We remade some like pre-printed exercise programs, which are really easy just to grab as people were going out of the door. Same goes for pre-cut therabands, which are readily available and easy to access, so you could just quickly grab some as you were going out the door. Regular email reminders to people that they should be doing these changes of 5-time sit to stands and progressing people and using therabands. And we also added the BEPOP column to our spreadsheet, where we talk through every single new patient every week. And so there'd be a prompt saying, are they appropriate for strength-based exercise input and inclusion in the BEPOP program? Next slide, please. So we did a lot better in wave 2, still stuff to work on. So 80% of patients now received a 5-time sit to stand outcome measure before starting. So that was up from, it was 15% before. The diagnosis about sarcopenia, I don't think we have really got on board with saying definitely people have sarcopenia or not. We should probably just discuss with our geriatrician what their thoughts are on whether in our setting it's useful to give that diagnosis, or perhaps this can be for discussion. For exercise prescription, all of our patients had resistance exercises, 75%. The pesky body weight, again, I guess you can't avoid it, but we did have 45% with therabands, so that was an improvement. Again, patients' exercises tend to be progressed by volume. Can't seem to get out of the habit of that, but 40% were actually increased by intensity, and that was also a big improvement, as we were at rock bottom. So where we kind of fell down really was doing the reassessment, which is quite frustrating, because when you've done all that good work and you've done your outcome measure to start off with, then only 35% of the patients got it again. But I do have to say, unfortunately, some of our patients did deteriorate during the programme. I think a couple even passed away, and that kind of shows the demographic that we're working with, are very frail people who've just come out of hospital, and they seem like they're going to be appropriate to start off with, and then yeah, it obviously doesn't work out for everyone in our population. 20% of patients were referred on for further exercise intervention, and 10% were signposted, so that's something to work on. But as I said, the services are just dwindling in Hackney. They seem to be cutting a lot of services. Next slide. So what we learned, so change is possible, but it can be slow, and it needs a lot of pestering and reminding of people to take part, and having a very clear outcomes and what's expected. We need to do lots of education, prompting, reminding, chasing, and learning from other services. So it would be good to hear what tips other people have got for us. We've learned that we can actually make a really big difference in service users' outcome measures, so it's worth collecting so we can sing about it, really. And I found knowing that we were being marked on our work really made a difference, because we were a bit hotter on doing what we should be doing, especially as we'd had our report saying requires improvement in this part. So it told us exactly what we needed to do. Next slide. So the challenges that we came across. So our team is made up of lots of rotational staff, and as staff come through the team, we kind of maybe don't train them up on this aspect as regularly as we should. So we should probably offer more regular teaching. The time of year we did it, it was difficult. We had a lot of gaps due to holidays, leave, and recruitment gaps. So the time of year probably could have been better for us. We did it over the summer last year. The forgetting of carrying out the end data collection, deciding what we're going to do about diagnosing sarcopenia. Do we do it? Do we not do it? The challenges is our patient population who are very frail. And because we're a goal-based service, we are actually at the same time working on functional goals. So sometimes we need to do a functional session versus a resistance session. Although obviously the strength improvements will help the function. Opportunities for change. So we've shown that we can change, and we need to build on the good foundation. So we're relaunching because we're doing BEPOP 3, which is great. We've handed it over to our static band 6 physios. So it started off with the band 7s in the team doing it, and now we've kind of handed it over. Hopefully that will kind of embed it in the service more, because it will be further down and closer to the people, the band 6s of the workforce, really in the team, and supporting the band 5s to do it as well. It was sort of a little bit distant perhaps by running by the manager and the band 7s doing it. We just needed a few small changes to get a significant improvement. We somehow need to prompt to do the final outcome measures, and we're thinking about what we can educate the patients and what the best way of educating patients about sarcopenia is. And also provide further education to our therapy assistants so they know why they're doing the exercise sessions and why we're asking for it to be done in a very specific way. We also need to get some kind of pathway for the services that are still there, that we can easily know who to signpost to. Next slide. Planning to change. I think I've gone through all of that already. Yeah, we just need to decide what to do about the diagnosis and the education. So that's for the next wave. Thank you.
Thank you very much, Gemma. That was really interesting. We do have 5 minutes for a Q&A section now. So does anyone have any questions to ask Gemma from anything that happened in their service or anything that popped up that you would like to ask Gemma?
There's a question in the Q&A from Alice. Alice, do you want to ask that question?
If Alice doesn't, oh,
Yeah.
I was going to say, I can read it out. So Alice has asked, what services can we refer on to ensure that patients keep progressing with their rehab? Gemma, would you, yeah.
I think it depends on the locality. In Hackney, we've got various gyms and Healthwise that we can refer to, as long as people can get out and about. Unfortunately, a lot of our patients can't. There was some stuff being run by the council, but the council are cutting a lot of stuff at the moment. Unfortunately, there's no money. Probably the same in the rest of the country as well, I should imagine.
Would anybody else like to come in and speak to
I can add something quickly, Rhiannon, if that's okay. In Nottinghamshire, we have worked alongside a kind of a charity, but not really, to create a Google map of all strength and balance and PSI sort of provision across the whole county. So if I have a patient that's, as Gemma said, able to get out and about, I'll look on that map, look at their locality versus their address, and sometimes it's a direct referral from me, or sometimes it has to be a self-referral from the patient, but that's the sort of provision outside of NHS services that I would look for. So normally it's things like community exercise groups, maybe in a church or run by a football club or a cricket club, or the NHS is paired with another company. So in Notts, we have something called Your Health, Your Way, which provide postural stability classes. But it is going to massively depend on your local area, unfortunately, because a lot of these are just community groups that are driven by individual passionate people.
Thank you for that, Beth. Shahari, I'm sorry if I've mispronounced your name. Your hand is up. Would you like to come in and ask Gemma a question?
Yes, thank you. Thanks, Gemma. I think that's been really helpful to share your experience from wave 1 and wave 2. I'm part of wave 3 now, and I have done a bit of a qualitative study as well with the help of Suzanne here. So, and we are in the process of collecting the data. I just wanted to know, because wave 1, you got some evidence. So what is the reason you haven't been able to achieve the wave 2 results? Because people know that there is evidence, because I'm expecting our results going to be at the bottom scale, which as you said, the only way is to come up, which is good. But you already know the benefits of wave 1, and what is the reluctance of the staff to complete that in wave 2? Did you experience any challenges?
A lot of the time, so I think when you're doing something and you're doing a project and it's very important to you, unfortunately, with the best will in the world, it's not going to be important to everyone. And because we're goal based as well, people would just forget, and people are very busy going out and about. It's not that I think they don't care about doing evidence-based practice. It's definitely not that. I think it was more just forgetting to do the last one, or forgetting to tell the assistant to take the last sit to stand, 5 times sit to stand, and then it's just not time. It's just not a time priority to go and do a visit just to get an outcome measure. It's just requires a lot of hassling, pestering, reminding, emailing to get change, because it's important to you, but it might not be important to the people on the ground. I don't know if that's other people's experience.
Is it worth in developing like a checklist in the beginning, a checklist at the end? Is it something you thought about?
So we did make some changes and put it, so we put the initial on our NDN checklist. We could do it on the end, but I predict that people will be like, oh no, but I've discharged them already and I haven't done it. So but this is definitely on our plan for improvement, so hopefully we'll get there.
Thank you.
Thanks. Sarah in. Thank you so much. I'll bring Sarah in. Did you want to comment, Sarah?
Is that me, Rhiannon? I don't know. There's normally about 20 Sarahs.
Yeah, it's you. It's you. Yes, it is you.
Gemma, your presentation was lovely. I like to listen to. I really like your having your homework marked analogy. I think that we'll have to make sure that that's what everybody likes to have done in the future waves. A couple of things. I think the individuals themselves need to take responsibility, don't they, around the post-intervention assessment of outcomes. There's a behavioural change there that we wish we didn't have to do on the back of us all having the same undergraduate learning and hopefully postgraduate mentorship. But I think you've mentioned in the context of your presentation the funding issues many times, and I think if you are not demonstrating your impact through pre and post outcome measures, then you're already setting yourself up to fail around any opportunities to generate business cases or engage your leads and your system to invest more in your services. And so that would just you probably need to find the lever that's going to actually empower people to do that and to do it consistently. And then the question I had was, you mentioned a couple of times as well that you were a goal-based service, and that was one of the barriers to the. Was that a barrier to the exercise participation, or was that a barrier to the outcome measures being done?
I think it was a barrier to the focus of the sessions. So if someone's goal is to be able to walk to their kitchen and they happen to be sarcopenic, it's not always at the forefront of the therapist's mind to do that in the session, especially if someone's highly frail and quite fatigued and difficult to motivate. They might just end up practicing the functional thing. Ideally, it would be good to do both, but it would be interesting to hear actually why. And I don't think it's it's that people weren't doing the strength-based exercises, but perhaps they just weren't progressing people. A lot of the staff have rotated now from last year, so it's going to be hard to find out actually, but these are the challenges that we'll see in the wave 3.
Thank you, Gemma. Just in the interest of time, and I know we can keep going, I'm just going to move us on to the next speaker, but thank you so much for everyone's contributions. Please do continue typing in the chat box in the Q&A, and the team can be responding via text, via message rather, for further discussions and questions. Thank you so much, Gemma, and thank you.
Thank you.
Thank you. So moving swiftly on to our next 2 speakers. So we have Laura McKean and Lorna Costello, who are physiotherapists working with Northern Trust Community Physio Services, and they're going to be talking to us about how they improved their offer for sarcopenia across the board. Thank you both.
Thank you. I'll just try and share now. Is that
Great, we
there?
can see your slides. Yes, thank you, Lorna.
Can everyone see? Okay. Hi, everyone. I'm Lorna, and it's myself and my colleague Laura who's on as well. We're both community physios working in the Northern Trust in Northern Ireland, and we participated in Wave 2. Our oh, sorry, just thing to move on here. Our service is, I suppose, a fairly typical community physiotherapy service. There's a list there of the type of clients we encounter. Our referrals come from the community, GPs, nurses, falls practitioners, care home referrers as well. There's a separate stream for those who would be discharging from hospital and would have an ongoing rehab need. They're separate from us. We have a complement of band 7, 6 and band 4 staff, and we do cover a large geographical area. Now in Wave 1, I suppose our attainment scores weren't all that fantastic. You can see for yourselves there was a lot of low scoring percentages there, apart from exercise prescription, where we reckoned that there was a good delivery of resistance exercise training to the clients. This really provided a stark reminder of the need for valid and measurable outcome measures that could inform a sarcopenia diagnosis. I mean, part of the issue probably then was that a lot of our follow-ups were phone calls. That was becoming normal practice just due to service pressures. So actually, there was very little opportunity to reassess or consider progressing. So we simply weren't seeing those patients. What changes we made following Wave 1? So our colleague who was involved in Wave 1 shared her learning and insights with the rest of our team. And due to that participation in Wave 1 of BEPOP, we all then had a knowledge of the European Working Group guidelines, which meant we could purposely use those sarcopenia cutoff points in our assessments. And we could clearly document the sarcopenia as a problem and sort of place that into discharge and communication letters with anyone else who would have been interested in the client. Dynamometers were purchased as well for each of us, which obviously really assisted us from there on. Several of our team also went on a strength and conditioning course, and the key learnings from that have helped us to strive to deliver a more progressive home exercise program. So Wave 2 then did look a fair bit better. So we had improved in all our objectives, a big improvement in objective 1, which was assessment. So I think we went from 0 to 85%. Simply, we knew what outcome measures informed the European Working Group cutoff points, and we made sure we gathered that data. And that effectively was fairly easy to do. Those outcome measures that were useful for diagnosis are also widely acknowledged and evidenced as meaningful in our client group anyway. We also had our dynamometers, so that meant we could get good clarity on a sarcopenia diagnosis. And that then led smoothly into an improvement in objective 2, which was diagnosis. We had the outcome measures. We could cross-reference that with the European Working Group cutoff points, and that enabled, you know, a clear diagnosis of sarcopenia. Objective 3 was our exercise prescription, which we still sort of scored 100% there on both. So we in all our observed clients in each wave, we reported to provide guidance and practice of resistance exercise. I suppose we probably need to ask ourselves if that was always truly progressive. Then in objective 4A, which was our exercise progression, we improved from 0 to 15%. So we did recognize that we needed to try and progress those patients who we saw again or who we felt were capable of self-progression. And objective 4B with our reassessment of strength improved again 0 to 20%. I think really because we had then recognized we needed to see the patients more, or review more patients more of the time. So a bit more contact enabled us to have more reassessment. And objective 5, which was some improvement, still plenty of room for further improvement, and that has just been alluded to by Gemma in her previous talk, that there are some challenges there when it comes to where do our patients go when we have done with them. And then what have we learned from taking part in BEPOP? We have a much improved understanding of what to assess. We know that we can go and refer back to those working group guidelines. We know that sarcopenia is prevalent in our patient group, and that's not surprising. We can sort of see that diagnosis in some senses is fairly easy when you know what to look for and you know what to measure and you know how to cross-reference that with the information that's out there from the European Working Group. We have always felt that we have delivered an exercise program that included a resistance component, but maybe not just purely as progressive as it ought to be. We maybe need to get better at implementing our knowledge of progressive resistance training into simple functional tasks involving our major muscle groups. And even on a very sort of straightforward level, 3 sets of 10 is okay, but if it's going to be progressive, there needs to be more load with each set. So if it's bands that we're using, no band for set 1, yellow band for set 2, red band for set 3, or something like that. We acknowledge that often our exercises use body weight only, and we do need to consider how best to utilize body weight in order to be progressive. I suppose in a lot of cases we don't have a great deal of option but body weight. We haven't really got equipment in our patients' homes. We can't provide a whole lot of weights or anything else. Resistance bands, yes, we can use, but there probably are some barriers to that as well for some of our clients. And it has been mentioned before, we have to be mindful that just increasing reps is not the best way of improving dose. We've got to be realistic about what the time we expect our clients to spend on their given set of exercises. And we need to try to be innovative about the other training variables and look at things like speed of reps and time under tension, range of motion, concentric versus eccentric movements. Because those are other training variables that can influence the actual progressive nature of our clients' workload. So it's probably sort of food for thought on some of those. And then challenges to change. We sort of thought of this almost under 2 headings, like nearly with this service model challenge, that being that sort of age-old issue of capacity versus demand. We need to review them. Are we able to review them? How often can we review them? When would it be best to review them? Those kind of questions come to mind. And it's acknowledging that none of our services have an infinite sort of time resource. So I think we really do need to work out when we need to review our patients, how best to use those limited opportunities for face-to-face contacts and to reassess them to give us the possibility of progression. And the sort of notion of start slow, reassess and progress gradually for our client group would be reasonable and would be a good plan and would allow us to track our strength gains and functional outcomes. But the challenge being that sometimes our services just don't really allow for that. And then from a patient population challenge, our older, more frail, with more comorbidities, again, mentioned by the last speaker, a lot of our patients maybe turn out to be fairly unwell during the time that we are involved with them. So they may have neuromuscular or functional limitations. And we do know that our progressive resistance training is highly effective for maintaining their muscle strength and function. But those limitations, such as the physiological changes in older population, the reduced recovery capacity, their slower muscle repair and protein synthesis, alongside some of their chronic health conditions, can restrict really the exercise intensity and progression. And also the psychosocial factors, maybe motivation issues, maybe lack of supervision or support. And I would include sort of professional and personal in that can really impact their ability to work hard and their ability to progress. Individualized, well-supervised programs would reduce these barriers. And we often are a little bit inhibited in the exercise progression for our independent practice, because we have to make some sort of risk assessments about what our clients can safely do for themselves or by themselves. And even using bands for some of our clients can be challenging, because they may not be able to sort of don and off the band or tether it to a chair leg or whatever that might need to look like in order to use that effectively. There can be balance and trip hazards and so on there. And I also feel that asking our clients to independently does pose challenges. If we're asking them to push that wee bit harder into their sort of zone where they're likely to really make progress, that requires confidence, and having a trustworthy support and encouragement mechanism does give that confidence. And then our limited signposting options is something, again, that was alluded to in by the last speaker and during the conversation. We don't have that many places to sort of step off points for our clients. A lot of our voluntary or charity-led exercises in the community are sporadic and maybe non-recurring, little pots of money that pop up here and there, and that somebody produces perhaps quite a nice class or a nice format, but it doesn't continue and it doesn't recur, so it's not there for ongoing use. So there probably are challenges there, and we don't have all that many places to send our patients to when we are finished our service. And our opportunities for change, again, thinking of the same sort of broad headings, our service model. I think we're now more educated in the complexities and importance of delivering a really useful and effective, safe, progressive intervention. So we're better equipped to challenge and sort of deviate from the preferred ratio of new to reviews. So we can better clinically reason those decisions when we're required to do so. Being able to sort of quote that we even have small improvements in attainment of the objectives of an exercise like BEPOP upholds the value of our service and helps us to sort of promote what we can do. We've tried to do a little bit of enhanced triage as well, because going back to the sort of demand versus capacity issue, we don't have a lot of inclusion and exclusion criteria in our service, which does mean that we would always have a proportion of clients on our caseload that maybe aren't all that appropriate, in the sense that we actually maybe couldn't modify or influence the risk or concern in question. So we do try now to screen those a wee bit more thoroughly at the point of referral receipt, and that way we can process, maybe reject, provide guidance, educate our referrers a wee bit more. So that's having a little bit of an impact on the demand, with more work needed there. But obviously, if we have fewer clients on our books that we maybe shouldn't have or perhaps can't help, we maybe can claw back a wee bit of time to give to those who do need us for progression. those who are engaged. We also have more band 4s now within our service. We have a band 4 within each area, so that's quite new to us. We haven't had a lot of support worker staff up until now, so a few more boots on the ground, people out there to go and help us to deliver and review our exercise programs, so that's certainly really helpful. And then from our patient population, we are more knowledgeable in imparting that information to our clients, and we can more confidently encourage them to sort of the need to work a wee bit harder, the fact that their exercise has to be continuous, it has to be at an intensity that makes them work hard to create some change. So we know that we need to try and individualize a little bit more for these older clients as well. They are highly variable. They've got a lot of different physical capabilities and or physical disabilities. So we need to try and make sure that we're giving them a safe exercise intervention and include functional movements. And if we're doing that, we can aim to even create change through even modest increases in resistance over time. And so what are we planning to change next? Well, we have involved ourselves in wave 3, and we've got some of our band 6s doing that, including a couple of new staff to our service. So they're beginning to gather data to inform wave 3. We're going to share the knowledge gained from wave 2 and the reports that we've just read in the lead up to this, which we're really interested in reading. We'll be able to educate the rest of our existing and new staff as to how to assess for sarcopenia and how to aim to deliver more progressive resistance exercise training. And I think if we have that wider knowledge base within our staff will know what to do. And if they have that clinical suspicion of sarcopenia, they know what route to go down to try and confirm that and to then try and deliver an effective intervention. We are looking at sort of trying to create a bit better linkage, maybe with some of the public sector things. We need to know what's available so that we can signpost that and give that advice to our clients. So a little bit of a scoping exercise as to what's there, try and gather up a bit of data that we'll all have, that we can go, we know where we're going to look to advise our patients to go when they're finished with us. And maybe looking as well, we thought at online resources and see what's out there that other people are using that we could probably encourage some of our patients to go and look at some of those resources to follow some independent training. And that's something that would be so useful sort of from everyone else who's been involved with something like this, is what other resources are out there, what are other people using, what have people come across, and also and some of these things did pop up in some of the chat bubbles, but earlier on just about the timing of contacts and when people are seeing their clients, when are they reviewing them, and how many times are they seeing them. So those are the kind of questions I think we still feel maybe we haven't fully got a grasp of the answers to all of that. And also sort of the actual exercises and innovations and improvisations. Probably everyone has little gems of nuggets of advice they've done, little things they've come up with to help add load to their clients that some of the rest of us just haven't thought of. So that sort of concludes my talk. Thank you very much.
Thank you so much, Lorna. So in the interest of time, I'm going to switch the agenda slightly and we're going to go straight into Sue's presentation, and then we'll have a Q&A at the end for both Lorna and for Sue. So please, if you have any questions, please write them down, keep them in your mind, and we'll come to them at the very end. So last but not least, we have a final presentation from Sue Bridge. Sue is an advanced clinical practitioner working with Weymouth and Portland Frailty Service, and Sue is going to be talking to us about what they learned from joining Wave 2 of BEPOP. Thank you so much, Sue.
Hi, can you hear me okay? And
yes.
You can see my slides, yeah.
Yes.
So yes, I am in Weymouth and Portland, down in Dorset. We're a coastal town with a population of 76,000 people, over the national average of over 65s, and we actually have the highest amount of fallers in Dorset. Obviously, we've had a frailty service that over the last 10 years that's really focused on housebound and care home residents, but so we really recognise the need that we probably needed to start looking further sort of upstream and getting to the frail population sooner. So in 2022, we started an Aging Well clinic, which is quite a demedicalised model of delivering a comprehensive geriatric assessment in a very matters most approach. And as part of that offer to our population, we wanted to look at how we could improve later years, their quality of life. And one of the things we wanted to do is a development of a proactive exercise class offer from people attending the clinic. So I was actually really inspired by wave 1 of BEPOP. I'd heard about the results and we've read the report and looking at improvement of sarcopenia and measurement and how that relates to progression of exercise. So having attended the Agile and the BGS webinars and the community of practice, I was really inspired and as a team to consider what characteristics of an exercise programme would be associated with best outcomes. And we welcome the opportunity to benchmark best practice supporting interventions for sarcopenia. So we joined wave 2. And actually this coincided with very much of some of our work going on as an integrated neighbourhood team, and we were really looking to see if we could develop a framework of falls reduction pathways and how that could be developed as part of integrated neighbourhood team working. So what we did very much along the BGS document of reablement, recovery and rehabilitation, it's everybody's business. Everyone's important in this to really explore how we could reduce the risk of sarcopenia, frailty and falls in Weymouth and Portland. We called on, we had some workshops where we called on voluntary sectors, adult social care, the leisure industry. So we had lots of people involved in the workshops so we could start to look at sarcopenia and the best the right exercise for the right person at the right time. So this coincided with some funding that we had. Very lucky that we were able to deliver the Falls and Management of Exercise programme, FAME programme. So for our exercise offer, we could focus on FAME as the centre of our offer, using the strength aspects of this programme for sarcopenia and frailty. So this is obviously a tailored 24-week programme with effective strength training of load and intensity over time. As you can see, it's a multi-component programme, as I just said, so the strength being a component of that programme. And as you can see in the picture on the left, that some of our participants there using different coloured bands, so we were able to, the instructors, tailor the programme to the individual, so obviously using body weight or free weights or different resistance bands. The picture below actually shows another component of the programme, which was backward chaining down and off the floor. And it was really interesting to get comments from the participants to say that actually they felt as their strength improved, they were more able to get down and off the floor. So we had quite lots of feedback during looking at the programme. So what were the changes that we made? So from we started to introduce the sarcopenia screening in the Aging Well clinics. So we used the SARC-F screening tool. We use hand grip, and we started with the 5 times sit to stand, but we did change that to the 30-second sit to stand. We use timed up and go, but I've just put the functional grid there. That's a tool used as part of the FAME programme that's used. It includes timed up and go and sit to stand. And obviously the instructors delivering the FAME programme would use that at baseline and at 12 weeks and 24 weeks. So actually we were building into our exercise programme initial assessment, review, and then end of assessment. So how did we do in the BEPOP Wave 2? Well, from introducing our measures of sarcopenia, everybody had a diagnosis or proper diagnosis of sarcopenia. We were able to do the same reassessment at the start of the programme and at the end by using with a part of the FAME programme. And obviously part of the FAME programme was to use resistance exercise, and that in terms of delivering that in terms of dose and intensity. So we were able to, I've already said, repeat that assessment at the start and the finish of the programme. And we built into our programme also, the FAME programme is very much built on a behavioural and self-efficacy, but also we built into that programme sort of onward referral to other services and exercise providers. We have a very robust sort of social prescribing, and our care coordinators feeding into other programmes or services throughout Weymouth and Portland. So we were able to develop this aspect as well. So what did we actually learn from taking part in BEPOP? I think from actually screening for sarcopenia and in introducing evidence-based strength programme, we were able to really start to understand our population of reablement, rehabilitation, recovery across Weymouth and Portland, and that enabled us to really start delivering a really responsive frailty and falls pathway. So instead of really a very much a reactive pathway of waiting for people to fall, we felt that we were actually starting to move really upstream and looking at preventative intervention and enabling sort of very much in partnership across our integrated neighbourhood team to improve our health outcomes for our older people in Weymouth and Portland. Just moving on, so what are the challenges? The challenges are, I mean, we had PCN funding to deliver our evidence-based FAME exercise programme, and the evidence is there for 20 years of evidence. Some exercise is good, is not good enough, and that's the difficulty, is how do we get the commissioners to pick up the innovation to address reducing the risk of sarcopenia, frailty and falls? And I've given the example of the FAME programme. So locally we have identified the need, and it's whether that will align with national policy, and how we, one of the challenges is to build a business case for our service improvement for the future to make our outcomes sustainable. So I think there's really opportunities for change, and I'm really excited about the Fit for Future, the 10-year plan, because I think just from being part of Wave 2 in the BEPOP, we've actually really been able to integrate our falls and frailty pathway and start to look at preventative measures long term. So it's actually proactive identification and management of sarcopenia. So it's actually that shift from actually treatment of falls more to looking at prevention. So that's quite a whistle stop through my presentation, but I hope that gives you some insight into some of the work from Wave 2 in Weymouth and Portland.
Thank you so much for that, Sue. That was really, really interesting. Again, we don't want to take up too much of everyone's evening, or more than we already have. So if I could ask, does anyone have a question? One question, we take one question each, one for Lorna and one for Sue, from anyone in the audience. Sue, can I ask you just to stop sharing your screen as well, if that's okay, please? And I can just see everyone again, please. While Sue is just doing that, I will say, Lorna, we did have a question for you that Alex had posted. Now, I know you did kind of talk about this at the end, but I'll still read it. So the question was, hi, Lorna, surely just having senior physiotherapist involvement and no Band 5 physiotherapist involvement provides a barrier, as there is a lack of evidence from this demographic of physiotherapists? And that was asked by Alex.
Yeah, we don't have any Band 5s in our service. So if we had, we would have them involved. How's that? Yeah, we don't have a very big, we actually have, I suppose, a fairly small service. So at the moment, there aren't any Band 5s.
You did say there are some Band 6s that will be involved in the.
Yes, our Band 6s are, and that includes a couple of new staff members. So I think they'll be pretty enthusiastic about it, and I think that's a really good sort of move that gets them involved. But yeah, no Band 5s.
Thank you, Lorna. Does anyone have a question for Sue? Just having a quick look at the chat as well.
I've got a question for you, Sue, if nobody else has. I think one of the things that's really interesting to me is that you've solved a real challenge here, and that is, you know, adapting FAME to specifically deliver for people with sarcopenia and frailty. And we've had some interesting sort of conversations in the chat as this has been going on about, you know, the sort of focus on full specific programs versus sarcopenia or frailty specific programs. And I wondered if you could just sort of reflect a little bit further on that. I think that there's a model there that others could potentially follow, and it solves this challenge. Well, how do you deal with people who come in who are falling, and people who then you find they've got sarcopenia or they've got significant frailty? You know, do you give them 2 programs or 3 programs? You know, what happens if they've got heart failure as well? Is that a 4th program? You give them cardiac rehab. Yeah, so your use of FAME is a really nice model there, I think.
Yeah, I think we've got, I'd say, a less able FAME class and a more able so now, and actually and part of that FAME program is so tailored by the instructors, are crucial to delivering the program with fidelity and tailoring. So it's also built on that COM-B behavior. So it's about building self-efficacy as the program progresses, and it's very much tailored to the ability of the person, a very person-centered approach. So and I think the feedback from, you know, it's a real challenge. We have like the sit to stand challenge, and it's really building that self-management as well, I think. So the program itself can affect all levels in different ways. So it's been and obviously, that, as I said, that functional grid, I sort of went through that very quickly, but part of the baseline assessment, 12 weeks, 24, you've already building in that review at regular intervals and tailoring that progression onto end programs as well. So we've actually, there's been a development of onward programs within Wave and Portland, which is really exciting, because it's and we've been working very closely with the community rehab team about looking at sarcopenia and how we can look at what the right time is for the right exercise for the right person at the right time, and who delivers that as well. But yeah, it's really, as I say, it's a part of integrated neighbourhood team working. It's about everybody being involved in that across the population and voluntary sector as well.
Fantastic, thank you.
Thank you so much, Sue, and thank you, everyone. So that brings us to the end of this webinar. I think from listening to everybody from when we started with the results, the overall results of Wave 2, and hearing individual sites and their experiences, I think for me the takeaways are that BEPOP works. And I think as therapists, you know, I think we often struggle sometimes with exercise prescription and what that looks like, and also the management of sarcopenia, frailty, and how we manage for these for our patients and our clients. And I think this benchmarking program shows that, and it gives us tangible steps as a way to manage and help manage and care for these patients. So thank you so much to all the speakers. I think another important highlight that I'm taking away from the different talks that we had is that BEPOP allows us to see the small steps and progressions and steps. It's not a massive jump from 0 to 100, but it allows us to have those incremental changes again to lead to positive change and positive outcomes for our patients. And I hope that kind of was what everyone else kind of took away from it as well. So thank you so much to all our speakers. Thank you to all of the BEPOP team, and also for those of you who are in the audience, thank you so much for your engagement. Please do get involved in future waves. As we said, Wave 3 is up and coming, and Wave 4 is also being planned and in the works. So please do engage with the BEPOP team. There is the email, there is the website, also through the Agile website and social media, all the details are there. So please do engage, please do get in contact. And again, thank you to all the speakers, the team, and for all your engagement as well. And apologies for just running over time there as well.